Bienvenue. Welcome to the webinar, Expanding Youth Access to Mental Health Care, Lessons from a School-Based Study in Haiti. I'm Monica Ruiz-Casares, an Associate Professor of Psychiatry at McGill University and Coordinator of the Global Mental Health Research Seminar in the Faculty of Medicine. I will be the moderator in this webinar. With support from the McGill Global Health Program, the Quebec Population Health Research Network, and the Sherpa University Institute, our webinar series expands the training that we offer at McGill at the summer program in social and cultural psychiatry, which this year celebrates its 25th anniversary. We hope that these webinars will help raise awareness of the mental health disparities around the world, exchange social, cultural, and critical research in global mental health, and build bridges across languages, sectors, and geographical locations. We're delighted to have you join us today. We have two speakers today, but before I introduce them, let me highlight a few important features of this platform that will facilitate your participation. If you're joining us directly from your computer or the VoiceBoxer mobile app, notice that you can select your language of choice, English, French, or Spanish, at the bottom of your screen. The speakers today will present in English and in French, but once you select your preferred language, you will not need to change it. Just stay in that channel and the interpreters will do all of the work. Also, your microphones are all muted, but you will be able to send questions for the speakers at any time and in any language during the presentation at the chat at the bottom of my image in the screen. You cannot see the presenters or chat if you're connecting through a cell phone, though. For any technical issues during the webinar, you can contact the VoiceBoxer support team by clicking on the question mark icon on the bottom left-hand corner of your screen. So let's move on to the core of our session. Our speakers today are persists and Dr. Anne Becker. Dr. Becker is a psychiatrist and an anthropologist. She's the Maud and Lillian Presley Professor of Global Health and Social Medicine at Harvard Medical School. Persists is the Director of Mental Health and Psychosocial Services and Senior Psychologist at San Mila Sante, the Haiti-based sister organization of the NGO Partners in Health. He's also a PhD candidate in clinical psychology at Incheon International University. Persists and Dr. Becker were co-principal investigators for a recently completed youth mental health pilot intervention in Haiti, funded by the National Institutes of Mental Health in the US. We're honored to have them both with us today. Hopefully connectivity will be good and speakers will be able to take turns in presenting the material. But we know it's rainy season in Haiti. We had some challenges when we did the test yesterday, so I thank everyone in advance for your patience as we try to provide a very smooth webinar. So I will now pass the floor to you, Anne, to get us started.
Thank you so much. Good morning, everybody, and I am delighted to be here this morning, and with great thanks to our hosts at McGill and Dr. Monica Ruiz-Casares. And delighted to be here with my friend and colleague, Persists, who is joining us from Haiti. And we just wanted to begin by thanking heartily the members of a very large research team who collaborated and made the work possible. Persists.
Through the strong involvement of so many people from the ground here. We had Hermaz Louis-Pierre, Marie-Flore Chips, Reginald Fizeme, Catherine Oswald, Fernand Leon, Louise Ivers, Dave Golodi, Jennifer Sieber, Tatiana Torosme, Emina Frico, Anne Sorigen, Élisée Noisy, Léa Alexis, and he was working in Petite Rivière. This has been the team working relentlessly on the ground in Haiti, trying to gather together for meetings, trying to reach out to teachers, trying to reach out to students, to have all of these people gathered in a whole family, aiming to the same direction, and trying to find what we needed to better understand mental health issues among adolescents in Haiti. And
So we're going to describe a school-based intervention to promote mental health among students in Haiti. And to begin that discussion, we just want to situate this in a broader discussion about task sharing in global health for leveraging scarce human resources in low resource settings, and also, of course, for extending those services deep within the community. Per Eddie?
Yes, and thank you. Why have we tried to do this research? And we tried to understand exactly what was ongoing in the school milieu about the needs, about the unmet needs of the among the students. And when we tried to reach out to the teachers and the principals, we found out that we could bring this project in a way to not only to raise motivation, but as well to bring something in the direct line with the post disaster in Haiti after the earthquake in 2010. And we relied on the proximity we had with the school milieu. We consider as well that bringing this research would be a plus for the professional skills among the teachers, and it would be like a good investment for them as well. We considered as well the burden of mental health issues among the students and the risk they are exposed to, they are still exposed to, and the fact that their access to care is still poor. And we have considered that as well as a way for us to reach out to the parents who most of the time feel disempowered in front of turmoil the kids have been experiencing. And what I want to add as well, it is about the advantage of this school-based platform. And over the last 30 years, Zamila Sante has put in place a community-based approach, a community-based health program approach that could be, we consider, replicated in the school milieu, but instead of having community health workers, we would have teachers as people who can stand close to the students, our main target for this project. And we consider as well that transportation, which used to be a strong barrier for people to access to care, because people in the rural area are living far away from the clinic. They have to support transportation fees, and since the kids have to be present on a daily basis for 5 days a week in the school, this will be a way for us to lower the transportation barrier, and at the same time we took advantage of the intellectual curiosity among the teachers, where we thought that this research would have been an opportunity to bring more information to as well to have interventions that are well targeted, that are universal, that experience that are shared by so many people around the world, and at the same time to make sure that once we find a problem, these students, on the recommendation of the teachers, would be linked to the health sector that is close geographically to the schools. And
So as you heard from Per Eddie, we chose to focus on a population of young people, partly because we could strategically deliver evaluation and assessment and potentially treatment at school-based settings, and also, quite frankly, because the adolescent and young adult population is relatively neglected in low resource settings by virtue of less experience with care seeking, and also fewer touch points with the health system that are kind of structured in. Moving on, Eddie mentioned the post-disaster setting, and many of you will recall the devastating earthquake in Port-au-Prince in 2010, which was absolutely catastrophic. It was centered in a residential area, and there were estimated to be about 200,000 or more deaths. And of course, many more people were orphaned, displaced, and it was a high crisis time in Haiti. And many of you will also recall it was followed by a cholera epidemic. At the time, a local NGO, Amis la Santé, which is a sister NGO to Partners in Health, which is headquartered here in Boston, was operating in a relatively earthquake-safe region in Haiti's Central Plateau. And although they were already delivering mental health services at the time, and Per Eddie was leading this effort, the acute needs superimposed on the chronic mental health needs, as well as new resources flowing in, presented an opportunity to build better and stronger mental health services in the community. Per Eddie?
De dire que pour entrer dans la dynamique de ce désir de nous approcher de ce monde adolescent avec ses problèmes, nous avions beaucoup plus de questions que de réponses. Nous avions beaucoup plus de doutes que de certitudes. Nous voulions savoir, nous voulions découvrir ce qui pourrait servir comme fondation pour ce projet à l'intérieur du modèle éducatif en vigueur en Haïti, particulièrement dans le milieu rural. Nous avons compris que nous n'avions pas tous les détails et il nous fallait nous référer, nous fallait compter sur la sagesse et la sollicitude des professeurs pour pouvoir connecter ces jeunes à la réalité de la santé mentale. Et je pense que nous n'avions pas fait fausse route puisque cela nous a donné les résultats que Dr. Baker va vous présenter tantôt. Anne?
So we, as Per Eddie was saying, we checked in with the principals at several of the schools. We held focus group discussions to find out whether or not educators would be willing to join an effort to promote mental health in the schools. And fortunately, the principals in the schools and the teachers were enthusiastic about this event. So with our team, we asked the question, how can we build this effort and how can we assess whether teachers can facilitate youth access to mental health care? This was a task sharing effort that is a little bit different from conventional task sharing when non-specialized health professionals may deliver services. In this particular case, we were actually hoping that the teachers could be strategically placed with their professional skills already in place with, pretty much a front row seat on the students and knowing in many cases whether or not students were advancing along the trajectory that was expected academically and socially. And we wanted to see if we could equip teachers with the skills to accompany students who might be in need of mental health services and facilitate their access to the services that were now being offered in the region. And the program that we developed was a small pilot study, and it consisted really just of 3 parts. The first was training for the volunteer teachers. Teachers were nominated by principals at 4 schools, and based on their interest, they stepped forward, and we offered them a several-day residential training, and we called this training for their role as teacher-accompagnateurs, emphasizing a locally familiar idea that teachers would be accompanying students and helping them by supporting them in many ways, morally, with information, practically, etc., in accessing care. The next step of our pilot was to actually assess by a mental health screening what the local prevalence or burden of 2 key disorders were major depressive episode and post-traumatic stress disorder. And then finally, our plans were to facilitate one-to-one teacher-student meetings for all of the students screened, not just the ones who were screened as having one of these disorders or a related disorder, but actually for all students, to see whether or not a student-teacher meeting that offered an opportunity to discuss mental health services available and supported students in accessing those services, to see whether or not that could close the treatment gap locally.
When we gathered the teachers for the first training, and we had as a main goal or objective to make sure that after the training and for all of the project, the teacher would keep the 4 R's, and with that are recognizing, how to detect signals of distress among the students, how to respond, how to refer, because the teachers as accompagnators cannot address the issue on their own. They had to refer, and at the same time, the four R is how to build and promote resilience among the students through activities and advices, tips they can share with the students. And at the end of the project, we had another R as an outcome in a lesson we learned. It was about to reach out to the most vulnerable. This has been a way for us to make sure that these key points can remain not only in the teacher's mind, at the same time a way for us to make sure whenever they receive a student, they will keep all of this in mind. And at the same time, when we try to put all of this together, we started a retreat where we decided to first to convince the key people we needed for this project. First, the principals who were supposed to give us approval and permission to reach out to the teachers, and at the same time to the students. And the success or the failure of this project laid on them. And at the same time, we had to rely on the clinical team. You can see the picture on the next slide, Monica, please. You can see the small.
So, Per Eddie, I think we had a technical difficulty there. I'm going to pass back to you, Per Eddie, so you can just contextualize the region where the study was created, related to where the earthquake occurred, where the new facilities have been built, and where the schools were. Per Eddie?
We are in Haiti, in central Haiti. We call it the Central Plateau. And after leaving Port-au-Prince for the psychosocial program to help people affected by the earthquake, we moved back to the Central Plateau where Zamila Sante has been founded. And we chose 2 main sites. We chose Kanj, who used to be like a place of pilgrimage, health pilgrimage for many people who are facing AIDS and TB. The Kanj has become famous because of the work of Paul Farmer in the public health field, and we went as well to Wench, where we chose 2 schools from each place, and we had one of the school was a public, what we call in French a lycée, a high school, a public high school, and this has been for us the opportunity to make sure that we have the core people we needed for this project. Okay, Anne?
Thanks, Per Eddie. So to review just a few pieces of information about who participated in the what we call TAPS, the teacher-accompagnateur pilot study. Per Eddie approached 4 schools in the Central Plateau of Haiti. We asked the principals to nominate teachers who might want to participate as teacher-accompagnateurs, and 22 were enrolled as participants. And then we went to each of the 4 schools and requested an enrollment roster to randomly select student participants within each of those 4 schools. And a total of 120 students completed the study. And I want to point out that these were actually aged 18 to 22. They were in secondary school. There were a variety of reasons that we can go into later during Q&A if people are interested as to why we chose these transitional age adults who were 18 years old at least, but as you can see, there are quite a few in secondary school at that age. And I will pass back then, Per Eddie, to you to review the key components of the teacher training, please.
This slide, I don't want to repeat myself too much, but we wanted to have we base out the project, the training of the teachers on the 4 R's: recognize, respond, refer, and building resilience. And at the end of the project, we added a new one that we call reach out to vulnerable adolescents. And as we said as well, for the next slide. Can I move? Yes. We had as a team to find the best way to mobilize people, to mobilize the principal, the teachers who, as mentioned, that they were selected and proposed by those principals, and how the best way to engage these people, and the excitement we witnessed from these people was so motivating to us, for us, because while we were thinking that it would have been difficult, people showed so great enthusiasm that made the work much easier.
So we want to discuss just for a few minutes the sort of how we assess the teacher training, because our first stop, of course, was teacher training, and if that hadn't worked, the pilot program really couldn't be successful. So the first area that we examined was whether or not the teacher participants thought of this training or experienced it as workable within their lives and acceptable locally and culturally. And I know this is a busy slide, I apologize for that, but basically what you see here are the teacher responses after the training on a Likert style scale, and the areas that are in red mean disagree, or correspond to disagree, and the darker blue with agree. And as you'll see there, that the questions that were geared toward, was this a negative experience or a difficult experience, were generally disagreed with by the teachers, and the positive type experiences were agreed with. So overall, the gist of it was that the teachers found the training to be feasible and acceptable. In fact, as Per Eddie mentioned, they were quite enthusiastic about it. The next question we had was whether or not the teachers increased their knowledge of mental health with the training. And to assess this, we developed a simple self-report knowledge assessment that we asked the teachers to respond to just prior to the training, and then we gave them the same assessment immediately following the training. We gave it to them again several weeks later, between 4 and 6 weeks later, at the very end of the intervention program, to see whether or not the gains in knowledge were sustained. And as you'll see here, the teachers did gain significantly in knowledge between the pre and post testing, and that knowledge was retained or the gains were sustained over the course of the program. We were also very interested to see whether or not the training changed the attitudes of the teacher participants with respect to the importance of mental health care and the value of seeking services for it. So we also asked them to respond to a self-report assessment around attitudes. And we found that, and you'll see here in the next slide, that the attitudes became significantly more positive between the pre and post testing times, and you'll see here that those gains were also sustained through the end of the intervention period. And Per Eddie will talk.
Yeah, and what I would like to add as well, one of the key findings that I considered as amazing, it was a strong improvement and a change of paradigm among the teachers in the relationship with the students. In the Haitian culture, teachers represent, or they are like parent substitute. And the model of relationship they have with students is based on authoritarianism. After this training, we witness a spectacular switch of the paradigm where the teachers learn how to better communicate, how to master the ambience of the classroom. Instead of using the power assertion model, they were more open to understand what was going among the students, how some behaviors that they were showing in the classroom could be related to other issues that have nothing to see with good education or not. And this, to me, has been one of the main point of awareness raising among the students, among the teachers, about the student reality. And for the work, for this work we have done, we in addition to the teachers training, we had as well to get closer to the student and to start the clinical piece with them, trying to involve them and to enroll them in a process of screening where, as I mentioned earlier, these 120 students were screened by the clinicians working for Zamila Santé for depression and PTSD. And Tatiana, you will see on the next slide, is one of these clinicians who have been very instrumental in putting all of these together. And please feel free to add about the outcomes we found from the MDE and the PTSD when we screen the students.
Yeah, thank you. And as Eddie said, here's a picture of Tatiana during one of the teacher training sessions. And for the screening, we wanted to use as an interview-based screening. So we used a modified SCID interview to assess major depressive episode and post-traumatic stress disorder, and what we called subsyndromal but clinically significant variants of those two. But since the SCID hadn't been used in this region before, we didn't want to just rely, we were interested in, of course, the prevalence, but we didn't want to just rely on the SCID for identifying students who may have clinical needs. And so at the same time, we invited the student participants to also undergo a routine clinical interview with one of the Zamila Santé clinical staff at the school. So we offered it. It wasn't, we told them it was not part of the study. It was available to them for their own information. But afterwards, we invited them to release the information back to the study if they were willing to do that, since it would be helpful to us. But the idea here was that a clinician would deliver or would offer an evaluation, which was really equivalent to the usual opportunity for someone to be evaluated for mental health needs. And that clinician discussed with the student participant whether or not he or she might have a problem that would benefit from clinical services in the area. And if he or she did, that clinician gave information about how that student could access clinical care. So that was separate from the study, but obviously highly relevant to the study. Now, I want to show you what we found. And remember, this is a random sample of students from these 4 schools, and we've highlighted the area in red that we wanted to pay attention to, which is the very high prevalence of students in our sample who either had major depression, PTSD, or both, or a clinically significant subsyndromal variant. And these were identified by the modified SCID interview, as I said. Now, because the SCID interview was new in this region, we wanted to provide some assessment of its validity. And you see here in this slide, and highlighted in red, that we looked at self-report measures of known constructs which overlap with depression and PTSD, and we found significant associations between those measures and our SCID-based diagnostic assessments. So we were satisfied that the diagnostic classifications we'd made were valid in this particular context. I want to show you one more slide before passing back to Per Eddie, because this is really the crux of the matter, which is that of the students we identified, and that was 44 with one of these clinically significant mental health problems, a high number had not accessed mental health care in the past 12 months. In fact, as you'll see in the small wedge in the graph in blue, 11.4% only had accessed mental health services in the past 12 months. You'll see here that a larger percentage had accessed some healthcare, general healthcare, but of course we don't know that that would have necessarily been mental health care. And a special concern was that a large percentage, 43%, had not accessed any general healthcare or mental health care in the past year, even though they were presently suffering from one of these clinical mental health problems. Per Eddie?
Maintenant, les professeurs ont été formés. Les étudiants ont été choisis. Nous voilà maintenant à la dernière phase pratique du projet. Les professeurs sont prêts à recevoir des étudiants et à les accompagner. Les rencontres sont préparées, sont bien arrangées de la manière la plus sécuritaire pour les étudiants, et ceux-ci ont été capables effectivement de les rencontrer. Les rencontres ont eu lieu, et à cette phase de la recherche, nous avons pu découvrir beaucoup de belles choses. Nous avons pu découvrir aussi moi ce que j'appelle avec regret, des misères que connaissent les étudiants et qui sont liées à notre système social. Anne, je ne sais pas si vous pouvez partager maintenant avec l'auditoire les découvertes que nous avons eues par rapport à cette expérience pratique avec les professeurs, s'il vous plaît.
Yes, thank you, Per Eddie. So first, as Per Eddie said, we started with an assessment of how the intervention had worked. And remember, we had very, very modest goals. Our goals were for teachers and students to arrange one meeting during the intervention period, which is 3 or 4 weeks long. We, after assessing the students, and it didn't matter if they received the information that they had a mental health problem or not, we asked them we provided them with the name of the teacher at their school they should be in touch with, and likewise we provided the teachers with the names of the students who would be in touch with them. And we offered them support if they asked for it, but we asked them to go ahead and arrange these meetings themselves. And I want to tell you a little bit about what we found just in the logistics of implementing that, and then we'll move on to what Per Eddie alluded to about some of the deeper problems we discovered in the community that the students told us about, and the teachers as well. First of all, in this slide, and again, I apologize because it's a very, very busy slide, we assessed how the students and teachers felt about the program, whether it was feasible, acceptable, and useful to them. And the main takeaway from this slide is that that the teachers and students were very closely aligned in their perception of the program. As you'll see here, the student bar is on top, teacher on the bottom. And in general, their assessment was very positive. So when we asked if there were negative experiences, they generally disagreed that there had been negative experiences, and for the positive elements, they generally agreed. I want to move on to talk about a result that we feel very mixed about. This bar graph shows the percentage of students and teachers who actually succeeded in having a meeting during the intervention period. And the good news is that more than half were able to arrange a meeting, and the not so good news was that only about half of the students arranged a meeting, and not all of the teachers were able to arrange a meeting either. So of course we wanted to dig a little deeper into that, and as you can imagine, there were many logistical problems, but we were also concerned that perhaps the students were voting with their feet, and perhaps it was difficult for them to contemplate talking to a teacher about mental health needs. Now, for each student-teacher meeting, we asked the teacher to fill out a brief encounter form, and we asked that teacher to tell us what he or she talked about with the student. We had instructed the teachers to invite the student to talk about mental health questions and mental health treatment needs, but to be very flexible if the student didn't want to talk about it. We also suggested to the teachers that they could offer to the students to talk about study skills and just general emotional well-being and health information. And as you'll see here, the discussions about academic skills and general well-being were very popular, but the mental health treatment discussions were also quite popular, and 75% of the student-teacher meetings included some discussion about mental health treatment adherence. So you'll remember that we had identified 44 students who had a clinically significant mental health problem, and we really wanted to know whether or not the students who had those problems, who were not previously accessing mental health care, could be helped by this kind of intervention, by having a teacher-accompagnateur who was empathic and informed about local services, meet with him or her and support him or her in accessing treatment. And what we see here is that of the students who had a clinically significant problem, over half of them, over half of the 19 who had not accessed health services in the last year, actually did meet with a teacher and did talk about mental health. So we considered this a modest success because we were reaching a difficult to reach population of students who had need and who were willing to accept help, and this was a way for them to access that help. Now, in wrapping up in terms of our lessons, I'm going to just pass over to Per Eddie to talk a little bit about what did we take away in terms of lessons from the teacher-accompagnateur program. Per Eddie?
We needed to find something to keep after doing this project, and we found out that first this training was pretty effective, and teachers expressed appreciation. They were enthusiastic about the notions, the knowledge that was shared with them. But what was a little bit heartbreaking to me, it was the fact that despite these students, most of these students were not exposed directly to the earthquake in Port-au-Prince, and we found out that the burden of depression and PTSD among them was significantly high. And this is, to me, one of the points that remains important and critical for us to keep addressing from the ground. And we thought in the beginning that students would have been reluctant considering the quality of the kind of relationship they used to have with the teachers. No, there was no reluctance. They were very enthusiastic. They were willing to meet with the teachers. And we understood as well that this school-based project can be to us a proof and evidence that any other program related to the findings of the research could be successful, because it would help to reduce barriers to mental health services and care among the students. And at the same time, if you will let me continue and for the next slide, I would say that the teacher experienced this kind of eagerness among the student to go to them and discuss. And when when the students showed so much enthusiasm and appreciation about what they experienced with the teachers, those teachers were themselves surprised to see that. And when among the adolescents, as they find their way of functioning in gang, the word of mouth they share about what they were experiencing in this project. Some of them showed disappointment because they would have been like as well to be part of the project, and because they were not selected, we did it from the we did it randomly, and they wish they could have been part of this project. And this has been to us not only a matter of simple curiosity, it is as a sign, a signal for us that many adolescents are looking for someone to listen to them, are looking for someone to take care of them among all these needs they have about their daily life. And
Yes, and here are some excerpts that illustrate what Per just described, and I know we're running short on time, so I'll just jump ahead to the next point we wanted to make, which is that we learned from the teachers, or we were reminded by the teachers, that in a low resource setting, the very same constraints and pressures that lead one to think about task sharing as a leveraging strategy to expand access to care also affect teachers. And in this setting, teachers had less bandwidth and fewer resources to take on extra responsibilities, and really exhorted us to think about providing more support to them, such as cell phone minutes and food for snacks for the students. Probably more importantly, we learned from the teachers that the students' mental health problems were there, and the teachers were appreciative to learn more about them, but they underscored that these were really entwined with social adversities that were endemic in the local environment, and that social suffering really had to be addressed too. And in the next couple of slides, there are some excerpts from the teacher focus groups that I will pass over to Per to talk about.
Just to mention that the teachers are more and more aware of the basic needs among the students that are not met, and this situation has been, for some of them whom I met privately after the training, who shared with me how heartbreaking it was to them when they were listening to the students sharing about the situation of coming to school in the morning with empty stomach, etc. So this has been for them a real barrier in understanding the best way for them to do this accompaniment, but at the same time to understand how basic needs that when they are unmet can prevent students from performing well at school. And can you move forward, please?
And
yeah, when teachers say, for instance, a hungry belly has no ear, it's a way for them to show the sensitivity about this situation among the students, and they think that before we address mental health, we need to take care of the hunger problem among the students. And this is for us very eye-opening, and we hope that one day the ministry in the social aspect of these basic needs, will do something that can make the teachers more at ease to support students when this basic need about food will be addressed appropriately.
So teachers emphasize that that we should think about expanding the narrow scope that we had envisioned for task sharing, just focused on clinical relief for the students. And they helped us understand that they could be advisors and agents for change in reducing adversities and strengthening resilience among the students. And they also advocated for accompaniment by the intervention team for the teachers, as I mentioned before. Eddie?
Because the education system and at the high school level, teachers are not paid to spend one business day, one work day in the school. They are like selling hours. They can go from a school to another. So when we found out that asking them to spend 1 hour with a student for a meeting would mean for them a loss of revenue. So we understood when they say money should be part of the accompaniment they are providing to the student, this related to what they earn for living, and this has been beyond our capacity to do so. But at some extent, the next time, if in terms of scaling up as a project or as a permanent program, this is something that needs to be addressed, and we totally understand what they meant when they ask for money, because it is a way for them. It will be a way for them to not lose money, but instead to gain more. And
so to wrap up the key lessons in our last couple of slides, we just want to sort of summarize that instead of cultural barriers seeming to be the main difficulty that students were facing in terms of looking for mental health care, the teachers underscored that the social structural barriers seemed to be the most salient. They also helped us understand that the resource constraints that impact clinical care delivery also impact other sectors, including the educational sector. And then importantly, the teachers viewed a narrow clinical focus on mental health as important, but not enough. And they underscored for us that the benefits of task sharing could go well beyond leveraging mental health specialty expertise. And to close, I will turn over to you, Per Eddie.
Thank you very much. Merci en pile. Thank you. Thanks, Monica, and thanks everyone. Thank you so much, Anne.
Thank you, Anne and Per Eddie, for a very informative and critical presentation of the work you've done in Haiti to facilitate youth access to mental health care. I'm pleased that technology also cooperated, so we had a smooth presentation. Now we have only a few minutes left, and we'll go through some questions to all the participants. If you want to send any through the chat box, I'll get started with one and then pass the floor to Anne and to Per Eddie after I formulate each question. So let me go with one. While we may tend to think of children and adolescents as vulnerable to mental health risks, we also see resilience among them despite various adversities in their lives, as increasingly reported in other studies. To what extent resilience of students was considered in the study, and in what way did this accompagnement approach tap resilience of students, if it did? I'll pass it on to you, Anne.
Sure, that's a great question, and I'll say something brief, but then I want to pass it on to Per Eddie after that. So we did think about resilience, and in fact, in the teacher training, we had included some skills building for teachers to use in helping students do relaxation, etc. The other piece that relates to resilience was actually brought in by the teachers around the school milieu, and they pointed out many ways that they felt that the school could be a more supportive environment for the students. Per Eddie?
What you say is very comprehensive, and I don't think I have too much to add. And what we could emphasize it more. It's, how we could, from what the students have as their as in the place of living, as to help them better understand how they can get a better life, how they can manage stress in their daily life, but at the same time how to better understand that, first of all, they have people around them, and how the family can be supported, because we understood that sometimes when the family is a conflictual milieu, when there's too much tension in the family, it affects the students. And we could try as well to promote resilience in supporting the parents, because sometimes they feel lost about what's happening among their kids. Thank you. Monica?
Sorry, I don't know what happened with technology. It seems it failed in Canada after all. I hope everybody's hearing me now. I'll go and ask one more question. I think we have a few minutes. The teacher-student relation is power reading, and culture also affects the way that they build relationships. To what extent and in what way did the inherent power asymmetry between teachers and students influence the implementation of this accompagnement approach? What are the implications for adaptation of this approach to other social cultural contexts where the teacher-student relation is built differently? I'll pass it on to Perdi first.
I remember this question is great, because this has been from the very beginning one of the question Anne had before, because we were trying to see how connecting students to teachers, or connecting both of them together, how easy it would be or not. And we took into account the model of relationship between both of them. And in the Haitian context, this model has been mostly based on authoritarianism. And it was related to the same kind of, fear students have against their parents, and the same kind of fear they have against the teacher, because, as I said earlier, the students perceive their teachers as the parents, substitute parents, one thing. But if we can build confidence, we can help them understand that this is an accompaniment model where the teachers are willing to stand close to them, not to be, over-directive, not to be frightening, but just to help them understand what's going on, and help teachers as well to show more empathy, to show more understanding. This can help, remove the threatening aspect of the relationship, and try to replace it by, an effective accompaniment.
Yeah, exactly. And as Paredes said, that this was one of the primary concerns when we started, was whether or not a teacher-accompagnateur model would be appropriate in this setting. And we began, as we'd mentioned, with focus groups, actually not just with educators, but with youth and parents as well. And and that was one of the issues we wanted to examine very, very closely at the end of the study is, were these communication channels a reasonable platform to support access to care? And so during the training, as Parity said, we really emphasize empathic listening skills. And of course, we covered confidentiality issues and gave the teachers an opportunity to, reflect on their role. One of the surprises we had was during the 2.5-day residential retreat, we had brought a movie really just for entertainment for the teachers to watch in the evening and discuss, Freedom Riders. And the teacher participants were really moved by the subject matter of the movie, which portrayed a teacher and a positive mentoring relationship with students. And actually, this was the foundation of lots more very lively discussion among the teachers. The other thing I want to point out is that the teachers really registered their surprise and delight with how the students, when they initially had the meetings, they could, they were kind of waiting and watching for how comfortable would students feel in talking about these very sensitive issues. And the way one teacher participant described it was that it was like a hemorrhage of speech, that once the student got started, it was as though, the student just needed to talk and talk and talk. And finally, the teachers also commented on how this experience in both the training and in working with the students one-on-one was transferable for them to their classroom management skills. And they felt they had a different perspective, many of them, on how to respond to students in need. And, rather than respond to, say, infraction of the rules with punishment, to really try to understand what was going on with the student and try to intervene in a way that would be supportive and helpful. Monica?
Thank you to both. I'll ask quickly, we have a minute only, but there's one last question I'd like to ask to you. When task is shared by non-mental health professionals, can be perceived as additional work or burden by some volunteers if they do not find any tangible benefit, which can be a challenge in scaling up a pilot intervention in resource-scarce settings. To what extent did you consider sustainability of this pilot study of task sharing when designing and implementing the study? I'll pass it on to you, Paredes.
In Haiti, is like in many other settings, what is the most lacking to scale up with this kind of project is the political will. We need it. But for currently in Haiti, the momentum is not appropriate because we are facing instability, and the government is not really ready to move forward with that. But as long as we have a new situation where more stability, where the political will be stronger, we will advocate more to have this project scaled up in a way where the teacher will be compensated appropriately, and at the same time for the benefit of the students.
And I couldn't say it better than Paredes, but also just to add that we had a wonderful idea in feedback from the education community, which was to explore the idea of building in some of the training into the professional skills development that takes place already in as teachers get their training, to become educators, and to think of this as professional skills enhancement, something that will make them more proficient in their profession, but also that will help them develop and understand their students better. And also just to underscore that resources definitely would be important to sustain this program. Monica?
Thank you. We thank you to both. We're coming now to the end of the webinar. We'll send a brief evaluation to the email where you registered, or you can copy and paste the URL that appears in this slide. It will take less than 5 minutes for you to complete. It will help us greatly as we plan future activities. Finally, the recording of the webinar in English, French, and Spanish will be posted on the websites of the McGill Global Mental Health Program in the next few weeks, and also in the websites of other series sponsors whose logos you can see at the bottom of this slide. Thank you again, Peredi and Anne, and thank you all for your participation. I wish you a good end of your day and hope that you will join us again for our next webinar on July 10th. Take care.